A very good evening to all of you. I'm Dr. Soundarya, and today's topic of discussion will be fluorides in pediatric dentistry. Now, before we go into the MCQs pertaining to this topic, let's see just a brief about fluoride. Fluoride has been proclaimed as one of the essential elements for growth and development, and this is by both the FDA, the Food and Drug Administration, and also by the WHO, that is the World Health Organization. Now, if you look at the word uh, fluoride, the Latin word flu means to flow. And this is an extremely electronegative element that is present in the periodic table. So if you see fluorides, they are never available as a single component. They're usually a compound. So they're usually associated with another element in the in nature. So let's just start with the first question, which deals with the history of fluoride. So all of you are familiar with the leather shoe survey. So the leather shoe survey was conducted by A. Dean, B. McKay, C. Churchill, D. G.V. Black. So the answer is D, A, which is by Dean. So Dean was the first person to conduct this leather shoe survey in the year 1934. And the main aim of him conducting this survey was to actually find the geographic distribution of the mottled enamel in the US. The term mottled enamel refers to A. Hypoplasia of enamel, B. Stains on enamel due to fluorosis, C. Hypomineralization of enamel, and D. Discoloration due to erythroblastosis fetalis. So what would be your answer for this particular question? You can come onto the chat box and leave your options here. The answer is B, which is stains on enamel due to fluorosis. So mottling is a term which has been associated with dental fluorosis, and usually a mottled enamel will show spotting, and it is an endemic form of hypoplasia which is associated with dental enamel. So most of the times you will be confused with option and option B. That is why option A was placed there. It is a hypoplasia of enamel, but option B, that is stains on enamel due to fluorosis, is more apt for this particular question. So B would be your pick for the answer. Fluoride inhibits A. Lactodehydrogenase, B. Pyruvate, C. Enolase, and D. Hexokinase. So this is related to how fluoride plays a very important role in the prevention of dental caries. So the answer here is C. So fluoride inhibits enolase enzyme. Now, if you remember your basic biochemistry, enolase is one of the metal activated metalloenzymes, and what it does is plays a very important role in the glycolysis cycle. So this fluoride inhibits enolase, and the fluoride ions basically prevent the alcoholic fermentation and glycolysis of enolase. So because of this, there is no formation of your dental caries take place. Or basically, you don't have glucose, so obviously there is no decay. Which of the following contains fluoride naturally? A. Wine, B. Tea, C. Fish, and option D is a combination of option B and option C, which is tea and fish. So your pick for this answer is going to be option D. Naturally, tea and fish do have fluoride in them. Tea has about the highest concentration of fluoride, and that is about 56 ppm, that is 56 parts per million of fluoride. And this data has been collected from the tea growing nations, that is basically India, Tibet, and China. Okay, and in fish again, the fluoride levels are variable. It can be anywhere between 0.9 ppm to 3 ppm. Okay, so your pick for this question will be option D. So this is with the fluoride concentration in the dental tissue. Okay, so the highest concentration of fluoride is seen in A. Pulp, B. Enamel, C. Dentine, D. Cementum. So we all know that enamel is being the outermost layer, and that is what is more prone to decay. And since fluoride is an anti-kerogenic nature in nature, our most commonly we would go and pick option B, which is enamel. Here it's the wrong answer. It is cementum, which shows the highest concentration of fluoride. So your correct answer for this particular question is going to be option D. Okay, and cementum usually has about 4,500 ppm of fluoride in it, as opposed to enamel, which shows a concentration of fluoride between the range of 2,200 ppm to 3,200 ppm. Okay, so your option for this particular question is D. Now we'll be talking about the method of delivery of fluoride, and in this presentation I'll be primarily concentrating to you about topical fluoride. So, but you do have questions on the systemic delivery as well. So the method of fluoride which is suitable for the general population is A. School water fluoridation, B. Salt fluoridation, C. Fluoridated toothpaste, and D. Community water fluoridation. So here the question is for the general population. So in that case, the option will be answer D. Okay, that is a community water fluoridation. Now, where can you undertake this community water fluoridation? It can be done only in areas where you have a general water supply or a common water supply. Okay, and if you remember, there are a lot of studies like landmark studies regarding your water fluoridation, and so it has been proven to be one of the most efficient way of preventing caries, or and also one of the least expensive method. Which of the following is a mechanism by which the fluoride exerts its karyostatic mechanism? Okay, so A is incorporation of fluoride in the enamel of unerupted teeth. B, secretion of fluoride in saliva, which decreases acid production and enhances remineralization of enamel. C, fluoride in saliva helps in maturation of enamel of newly erupted teeth, which decreases caries susceptibility. D, all of the above. Now, if you look at this option, A and C are very similar. There is incorporation of fluoride in the enamel of unerupted teeth, and fluoride in saliva helping the maturation of the enamel in newly erupted teeth. So these both are same. And also from the previous question, you do know that because fluoride prevents the enolase enzyme, so obviously the glycolytic pathway does not take place. So there is no glucose that is present in the mouth, and thereby the acid production uh, comes down. So the correct answer for this particular question will be option D, which is all of the above. Fluorides show anti-caries effect when A, present in the bloodstream, B, present in ingested foods, C, present in plaque and saliva, D, incorporated in the enamel. Now, this again is a trick question because you know that fluoride is present in foods, and a part of it is taken up in saliva and plaque when you deliver it locally. So option A is being ruled out here. All right. Ingested foods, plaque, and saliva out of and incorporated the enamel. Out of these three options, the best option is option D. So that is why fluoride is basically indicated mostly in newly erupted teeth, okay, or recently erupted teeth, or just before you have the eruption of the permanent teeth. So that is where the uptake of fluoride is maximum. So the best answer for this particular question will be option D, which is incorporated in the enamel. I hope it is clear till here. Now, which of the following is not true for systemic fluoridation? We are still talking about systemic delivery of fluoride. So option A, fluoride drinking water not only acts systemically but also has topical effect through a release in saliva after ingestion. B, fluoride of water is the least expensive and most effective way to provide fluoride to a large group of people. C, salt, milk, sugar, flour are other routes of delivery for systemic fluoride. And option D, 0.5 to 0.7 ppm of fluoride is recommended for water fluoridation in cold regions. So, what would be your pick for this particular question? So, the question says, what is not true? Okay. Option A, that fluoride drinking water not only acting systemically but also locally is correct. Fluoride water being the least expensive and the most effective way to prevent dental decay in a large group of people is again the right option. So you are stuck with option C and option D. Salt, milk, sugar, flour, these have all been recommended ways of delivery of systemic fluoride, although it is not being widely practiced. Okay. So I good evening to all of you. I'm Dr. Soundarya. So option D is the option which is not true here. Okay. 0.5 to 0.7 ppm of fluoride is recommended for water fluoridation in cold regions. No, 0.5 to 0.7 ppm of fluoride is recommended in warm regions. So this is according to Richards et al. In the year 1967. So he said that depending upon the climate, the ppm of fluoride in water for water fluoridation should be adjusted. Okay, so since in warmer regions the tendency is to drink more amount of water, the fluoride concentration or the ppm of fluoride in water has been kept at a very low level. So you see, if you see it is less than 1 mm, so it's somewhere between 0.5 to 0.7 mm in very extremely hot climates. Okay, so that is somewhere around any region that shows a climate around temperature around more than 26 degrees centigrade. The ppm of fluoride should be adjusted to 0.5 to 0.7 ppm in water. Okay, and if you move on to more colder climates, that is colder regions less than 18 degrees centigrade, in such regions you tend to need to have a higher level of fluoride in the water. It is because the intake of water per day by individuals in colder regions is less, right? So you need to deliver more amount of fluoride in order to have a good anti-carcinogenic effect. So in such cases or in colder regions, your ppm of fluoride will be anywhere above 1.1 to 1.3 ppm. Okay, so this was given by Richards et al. The next question is recommended regime for school water fluoridation is by adding 4.5 times more fluoride. Fluoride, the second statement is fluoride added in school drinking water should be greater than normal as children stay in school for a shorter time of the day and not to compensate for holidays and vacations. So the options are both statements are true, both statements are false. First statement is true, second statement is false. And the last option is first statement is false and second statement is true. So the pick for this particular question will be answer A or option number A. That is because in school water fluoridation, which is a subdivision of your water fluoridation, you need to have a higher level of fluoride. One, because you have children of various age groups are going to school. And the second reason is in the second statement, which is that you need to compensate for the shorter amount of time that they spend in school. On average, most students spend about 6 to 8 hours of time in their school, and also you have a lot of holidays and vacations. So in order to compensate for that, you need to add more amount of fluoride, and which is usually 4.5 times more than the amount of fluoride that you add in a general water supply. Okay, and school water fluoridation is usually preferred in areas where general water fluoridation is not happening. Okay, so and our target has always been children because that is when the uptake of fluoride and with the eruption of the teeth, the effect of fluoride is better. Repeated applications of a fluoride agent will not produce tooth mottling because A. Fluoride concentration of solution is weak. B. Upland fluoride is neutralized by calcium in saliva. C. It is not fluoride that produces the mottling seen in fluorosis. And D. tooth is already calcified and cannot be altered in this fashion. So your answer for this particular question is going to be option D. Now let me explain to you why. Uh, Topical fluoride is of two types. So one that is done by the dentist in the office, and the other one is self-care, but where the patient does self-application of fluoride is done. So if you see you in topical fluoride, the amount of fluoride that you will be delivering is higher than what you would give in a systemic way. Okay, but even then, tooth mottling is not seen because it is for a very short period of time. So in a topical fluoride application, let's say you're taking a fluoridated toothpaste. Okay, the recommended brush time is anywhere between 2 to 5 minutes. So with that short period of time, your tooth getting mottled is not going to happen. Okay, and second thing is that the tooth is already calcified. So most of the time, topical fluid applications, if you see on a large scale, is for older adolescents as well. So in such cases, the tooth is already calcified, and there there can be no mottling that can occur. So your best pick for this particular question is going to be option D. Now this question is full of numbers. Let's just have a look at it. By what percentage are caries lesions reduced in someone who has continuously drank fluoridated water since birth? Okay. So these are basically a reference to our landmark studies, all right, of water fluoridation. So your options are A, 40 to 65%, B, 10 to 20%, C, 70 to 90%, and D, 30 to 50%. Okay, so the studies are very variable because there are some factors which each study has taken into account. So how could you actually approach a particular question like this? Option B is out of consideration because 10 to 20% decrease is not something that you would see with a fluoridated water. Now 30 to 50 and 40 to 65 looks like a probable amount, and C again is too high. 70 to 90% of anticholinergic effect is a little too high. So if you see a wider range is better to pick. Okay, so anywhere between 40 to 65% will give you a bigger range, right? So it is better if you choose an option which has a wider range. Okay, and in such for such a question like this option is answer A, which is 40 to 65%. Okay. Now we're going to talk about topical fluorides, right? So the technique of application for 2% NAF was recommended by A. Muller, B. Knudsen, C. Brudewald, and D. Mackey. Okay, so what would be your answer? The answer is B, which is Knudsen. Okay, 2% NAF is your neutral sodium fluoride. Okay, and this technique of application of your neutral sodium fluoride was given by Knudsen and Feldman. Often it's also known as the Knudsen's technique. So the correct answer to this particular question is option B, which is Knudsen. The choking off mechanism takes place after application of which topical fluoride? All right. So option is A, which is NAF, B, stannous fluoride, C, APF, that is acidylated phosphate fluoride, and D, sodium monofluorophosphates. So the answer is NAF, that is neutral sodium fluoride. So if you see, neutral sodium fluoride is one of the very first topical fluorides that we study. And in NAF, when it's applied topically, what happens is usually you follow the brush on technique or the paint on technique for application of your neutral sodium fluoride. In these cases, what happens is that your NAF, that is neutral sodium fluoride, reacts with the hydroxyapatite crystals, which is present in the tooth. Okay, so when this reaction takes place, your fluoride will combine with the calcium that is present in the enamel and form calcium fluoride. Now, calcium fluoride is the dominant product of this entire reaction. Now, the concentration is 2%, due to which the solubility of the product calcium fluoride is exceeded. Okay, and there's an initial rapid reaction which is followed by a drastic reduction in the rate at which the calcium fluoride is formed. And this effect is known as the choking off effect or the choking off phenomenon, because a thick layer of the calcium fluoride will be formed, and this thick layer of your calcium fluoride will actually interfere with further diffusion of fluoride when you are applying it from the solution to react with your hydroxyapatite proceeds. So basic idea is that you're painting neutral sodium fluoride on the tooth surface. Okay, so there is a higher amount of reaction that is taking place, and there is a layer of calcium fluoride which is formed. Now, this layer of calcium fluoride actually prevents the further diffusion of fluoride from your neutral sodium fluoride to react with your hydroxyapatite. Okay, so this entire mechanism that takes place is known as your choking off effect or choking off mechanism, which is seen only with your neutral sodium fluoride. Right? I hope this is clear. Right? If you do have any doubts, just leave a message so that we can get back to you. Fluorides should be stored in A, plastic bottles, B, glass bottles, C, stainless steel bottles, D, any container. Okay, so fluorides are basically better to be stored in your plastic bottles. Like I told you in the introduction of this presentation, fluoride is highly electronegative, right? So it really wants to combine with any other thing that it can react with. So what happens if you store them in glass bottles or stainless steel bottles is that, especially with glass bottles, there is silica which is present in the glass. So this silica will combine with your fluoride and it will form silicofluoride. Okay. Now this compound will actually reduce the amount of active fluoride that has to be available for its anti-kerogenic effect. So if you keep them in plastic bottles, they basically cannot react with the inert nature of the plastic bottles. So you prefer to keep fluoride in your plastic bottles and not in your glass containers. pH of NaF is A, acidic, B, basic, C, neutral, D, highly alkaline. Now this is a very easy and a straight short question because sodium fluoride is always you know uh, dealt with as neutral sodium fluoride. So basically it is 2% of neutral sodium fluoride, where how do you get this 2% is that basically you dissolve 20 grams of NaF in 1 liter of water. So that is how you get the 2% concentration. And this is neutral in nature. So the pH is somewhere around is at 7. Okay. So that is why it is known as a neutral sodium fluoride, as opposed to another topical agent, which is acidylated phosphate fluoride, which is actually acidic in nature. Okay, we will be talking about APF in the next couple of slides. Which of the following solution is chemically not stable? Okay, it is not stable. A, stannous fluoride, B, neutral sodium fluoride, C, acidylated phosphate fluoride, and D, amine fluoride. So your correct answer for this question is stannous fluoride. Now, stannous fluoride is another topical agent that is commonly used. Okay, it is available as 8% stannous fluoride and 10% stannous fluoride. And basically, 8% stannous fluoride is more commonly used than the 10% variety. What happens is that stannous fluoride, every time you use, has to be freshly prepared. Okay, if not, what happens is that the tin or the stannous, which is present in the stannous fluoride, gets easily oxidized to stannic fluoride. Okay, and the stannic fluoride is a compound which is actually very inactive and it does not help in an anti-kerogenic action. So every time a patient has to come, you have to prepare this stannous fluoride solution freshly. Okay, so it cannot be stored for a very long period of time. Otherwise, the anti-kerogenic effect is not going to take place. We're still talking about stannous fluoride. So metallic taste is due to, in SNF, is due to A, stannous triphosphate, B, stannic triphosphate, C, tin hydroxyl phosphate, and D, stannous hydroxide. Okay, so here you need to be very aware of all the compounds that are present once you add stannous fluoride to the tooth. Okay, so there are some compounds which actually help in the anti-kerogenic action. There are some compounds which will cause the metallic taste. Okay, so one of the most important, or one of the main reasons as to why you don't prefer stannous fluoride for topical action is because of the metallic taste. And it is due to option C, which is tin hydroxyl phosphate. Now, this tin hydroxyl phosphate or hydroxy phosphate gets dissolved in the oral fluids, and that is what is responsible for the strong metallic taste that comes along with your stannous fluoride application. APF gel contains all of the following except A, NaF, that is sodium fluoride, B, hydrochloric acid, C, hydrofluoric acid, and D, phosphoric acid. Okay. So what is APF? Acylated phosphate fluoride. Now, how do you prepare this APF? It is basically prepared by dissolving 20 grams of NaF. Okay, so APF gel contains sodium fluoride. Okay, and this 20 grams of sodium fluoride is dissolved in 0.1 molar phosphoric acid. So again, APF also contains phosphoric acid. And in order to make it acidulated, you had 50% of hydrofluoric acid and you adjust the pH at 3. Okay, so APF gel contains all of the following except your answer for this particular question is going to be answer B. Okay, APF is basically 20 grams of sodium fluoride, which is dissolved in 0.1 molar phosphoric acid, and you adjust the pH at 3. So throughout a lot of studies, what they found is that uh, it started off with neutral sodium fluoride. The basic your topical applications basically start off with neutral sodium fluoride, and they found that as you decrease the pH, you make it more acidic, the uptake of fluoride by your enamel is higher. So that is what made the researchers introduce acylated phosphate fluoride. So basically, it is NaF in a very acidic solution. Okay, and the pH for this is at 3. The intermediate product formed when APF is used is A, dihydrate phosphate, B, dicalcium phosphate dehydrate, C, fluoroapatite, and D, diphosphate calcium dehydrate. So this question basically deals with your um, products that is formed when APF reacts with your hydroxyapatite. So if you saw in neutral sodium fluoride, what happened? NaF reacted with hydroxyapatite, and then the major product that was formed was calcium fluoride. Okay, but here in APF, it is not that way. You have an intermediate product, and depending upon how much of this intermediate product is formed is how you will determine the anti-kerogenic effect of APF. Okay, so the answer is B. Okay, DCPD or dicalcium phosphate dehydrate is a highly reactive with fluoride and leading to the formation of fluoride. So the amount and the depth of formation of the fluoroapatite will actually depend upon how much of the depth and amount of DCPD is formed. So if more amount of DCPD is formed, that is more amount and more depth of DCPD is formed, your fluoride action also is going to have the equivalent amount and equivalent depth of anti-kerogenic effect. Gelling agent used in APF is methyl cellulose or hydroxyethyl cellulose, B, gelatin, C, nitrocellulose, D, agar. So APF is available in 2 varieties. It can be in the form of a solution, or it can be form of a gel. Gel has been more commonly used again because of its ease of use and because of its better acceptability with children. And the gelling agent which is used is option A, which is methyl cellulose or hydroxyethyl cellulose. Now, this is a picture-based question. All right. So what you see here is a tray. All right. Identify the picture. A, mouth guards for use in contact sports. B, foam trays for APF gel application. C, bleaching trays. D, impression trays. So definitely you can rule out impression trays because they don't not look like this. All right. Bleaching trays are more custom made and obviously they're going to have indentations of the teeth. They are not going to be like an edentulous tray as shown in the picture. So the correct option is option B, which is foam trays, which is used for APF gel application. Now, these foam trays are basically made of this styrene foam, all right? And as you can see, the upper and the lower arches are joined together by a hinge, all right? And this extension that you see, I'm just going to mark it here. So this extension is basically a lock, all right? So your APF gel goes on to this trough that is present here. About half to two-thirds is filled with your APF gel and it's then placed in the patient's mouth. Now, these trays are available in different colors. You get them in blue, you get them in yellow, and you get them in green. So each color represents the size. Okay, the smallest is in yellow, the medium is in blue, and the larger trays are available in green. Okay. Fluoride varnish will be indicated in all of the following cases: A, a patient with open carious lesion; B, a patient with active pit and fissure enamel lesions; C, patient with orthodontic brackets; D, patient with dental hypersensitivity. So now let's look at all the options. Definitely, you can use fluoride varnish in patients in the option B, C, and D. Okay, fluoride varnish is again uh, another version of your topical fluoride application. Basically, you have added a liqueur, okay, which makes it very sticky. Okay, fluoride varnishes are very sticky because of this, and they tend to stick onto the tooth for a longer period of time. However, if you indicate or if you apply fluoride varnish for a patient with an open carious lesion, it is not going to have any effect. It is probably going to exacerbate the condition. So fluoride varnish would not be indicated in a patient with an open carious lesion. So the answer for this particular question is option A. Durafat is an sodium fluoride varnish, silane fluoride varnish, another name for APF gel, D stannous fluoride varnish. Okay. So varnishes are basically available as Durafat and Flu Protector. Okay, and Durafat here is actually a sodium fluoride varnish. Here you have 6 grams of sodium fluoride, which is dissolved in an alcoholic natural organic solution. Okay, so that is Durafat, and the amount of fluoride that is available with this Durafat solution is 22,600 ppm. So this slide is, I'm going to talk to you about basically Durafat and Flow Protector. I'm sure most of you are aware of it, but this is going to be a quick revision of what you already know. So 22,600 ppm of available fluoride is seen in Durafat, and it is nothing but sodium fluoride in alcoholic solution of the natural organic varnishes. So your option for this particular question is option A, which is nothing but a sodium fluoride varnish. And Flu Protector is 7,000 ppm, has 7,000 ppm of available fluoride. And here it is basically colorless polyurethane liquid, which is suspended in chloroform. Which the following are appropriate instructions to patients after application of fluoride varnish. A, tell patient not to drink hot liquids or eat hard foods. B, inform the patient that if they notice any yellowing of teeth, this is not normal. C, instruct them not to brush or floss for at least 4 to 6 hours or up till the next day, which is better. D. Instruct them to remove varnish with normal brushing and flossing at the appropriate time interval. Now, which of the following is the correct instruction? It is option C. Okay. Patient drinking hot or hard liquids or hard foods is not going to really affect the efficacy of your varnish. Okay. And varnishes are basically a very transparent and colorless application that you see on the tooth. Okay. So usually they do not cause any yellowing until and unless the patient has eaten something yellow, because they are very sticky. Varnishes are very sticky and they tend to absorb the color quickly. So if they notice yellowing of the teeth is not normal, is not one of the instructions that you actually would give the patient. Okay. And D, instruct them to remove the varnish for normal brushing and flossing. No, you ask them not to brush and floss, in fact. So that is option C, because the more longer period of time the varnish is present in the tooth, the better is their anti-keriogenic action. Okay. So that is why varnishes are basically applied, and the patient is asked not to rinse their mouth, not to brush or floss for that day, and preferably eat foods that do not have any additive colors in them, because they tend to take up the color on the tooth surface. Okay, so your pick for this particular question is going to be option C. Fluoride mouth rinses are contraindicated in A. Patient with orthodontic appliances. B. Patients having erosions and root caries. C. Patients having hypersensitivity. D. Children under 6 years of age. So one of the other methods of topical fluoride application is your use of fluoride mouth rinses. Okay. Now again, this is a variety which is done at home. So this is a self-applied version of your topical fluoride application. It is not indicated, or it is contraindicated in a child under 6 years of age. Now, why is that? Basically because children under 6 years of age, um, the spitting is not very well developed. Okay, one. Second thing, most of the children, they are so they fancy this so much that their chances of ingestion and thereby having any effect on the gastrointestinal tract becomes higher. So fluoride varnishes are not, fluoride mouth rinses are not indicated in children below 6 years of age. We do recommend fluoride mouth rinses for a child above 12 years. Okay, so that is a safe bet. It is better to apply or recommend fluoride mouth rinses for a child above 12 years of age. The age-appropriated fluoride toothpaste to be dispensed for a child aged 4 years is A. Smear-sized, B. The entire length of the bristle, C. pea-sized, D. rice-sized. Okay. So this question is actually going to be dealing with one of the AAPD recommendations. That is the American Academy of Pediatric Dentistry. They have a certain guidelines as to how much of fluoridated toothpaste can be recommended for a child. So they say that for a child below 3 years, a smear sized or a rice grain sized amount of fluoride can be dispensed on the toothbrush. Okay. So now this question is dealing with a child who's aged 4 years. So for a child between or a child above 3 to 7 years, a pea-sized amount is recommended. Okay. So your option for your answer for this particular question is option C. So this picture here actually shows you the pea-sized, the difference in the pea size and the rice size. Okay. So the yellow toothbrush is the smear, that is a smear sized or rice grain sized amount of fluoridated toothpaste that is dispensed. Okay. The purple toothbrush shows the pea-sized amount. Now, this pea-sized amount is what is recommended for a child from 4 years to 7 years and above. Okay. Let's move on to the next question. Again, we are having a picture-based question here. The image of the teeth showing a tooth defect, which is the following cause: cystic fibrosis, fluorosis, chickenpox, Paget's disease. You can easily rule out cystic fibrosis, chickenpox, and Paget's disease because they do not cause any defect like this that is shown in the picture. Okay, so what you essentially see is a nice pitting with brownish discoloration that is seen on the maxillary incisors. Okay, and you can see some amount of some kind of lesions in the lower mandibular incisors. All right, so this answer is fluorosis, and this is a picture of your dental fluorosis that is seen here. Next question is features of acute fluoride toxicity are A. Nausea, vomiting, diarrhea, B. Abdominal pain, C. Ventricular tachycardia and fibrillation, and D. All of the above. So one of the acute features of acute fluoride toxicity is the option D, which is all of the above. In addition to nausea, vomiting, diarrhea, abdominal pain, and all that, you also see excess salivation, okay, and generalized weakness, all right, and there's also a drop in your blood pressure, and there's some kind of a mucosal discharge, and sometimes it can lead to coma if it is not being treated correctly. What is crippling fluorosis? A severe form of dental fluorosis. B. Stiffness and limitation of joint movements which immobilizes the patient. C. Calcification of blood vessels. D. Chipping of teeth. Crippling fluorosis is actually a severe form of your skeletal fluorosis. Okay. So the option that fits here is option B, which is stiffness and limitation of joint movements, which immobilizes the patient. Now, recent years, the decline in dental caries is in most of the developed and developing countries has been due to A. Number of dentists graduating from schools, B. Widespread use of fluoridated toothpaste, C. Dental health education, and D is a combination of option B and option C. Okay, so the best pick for this particular question is option D, which is because of the widespread use of fluoridated toothpaste. Okay, and also more awareness that has been shown in the form of your media and also from your dentists. Now we're going to have a case scenario here. All right. So you are a dentist in a general dental practice. A mother has brought her 2-year-old son for his first dental appointment. The mother is unsure whether she should give her son fluoride supplements as they live in a non-fluoridated area. So now very important for you to notice here is two things. One is the age of the patient, okay, and another fact is that they live in a non-fluoridated area. Okay, so let's go on to the next part of the question. Your advice on fluoride to this mother and son will be: child does not require fluoride supplements. Supplement with 1 gram of fluoride, or you supplement the child with 0.25 milligrams of fluoride. And the last option, supplement with 0.5 milligrams of fluoride. Now, option A is ruled out because they're living in a non-fluoridated area. So you have to give fluoride, and especially the mother is asking about it, right? So you are confused between option B, option C, and option D. Now, what I'm showing you is one of the guidelines that has been given by the AAPD again on fluoride therapy. All right. Like I said, you have to see the age of the child and whether the area has been fluoridated or not. Okay. In this particular case, or in this particular case scenario, the child is 2 years of age and they are living in a non-fluoridated area. Okay. So if you look at this table, the best pick is 6 months to 3 years. Okay. And since they live in a non-fluoridated area, obviously the concentration of fluoride is less than 0.3 ppm. So you would give them 0.25 milligrams of fluoride supplement. Okay. So for this particular question, your answer is going to be option C. Now, this table is a very important table. Okay. Easy to remember things are that you do not give fluoride to any child who is less than 6 months of age. Okay, whether they live in a fluoridated area or a non-fluoridated area is not a matter here. It's all zero at the first row. Okay, If the child is between 6 months to 3 years of age and they live in a area where the fluoride concentration is less than 0.3 ppm, then it's 0.25 milligrams. So this was the case scenario that I had presented to you. And as the age increases, for up to 6 years to at least till 16 years, if they live in an area where they have less amount of fluoride, that is less than 0.3 ppm, then you give milligram. Okay, if they live in an area where the fluoride amount is between 0.3 to 0.6 ppm, you give them 0.50 milligrams. Now, another question could rise in your mind. Here, the question said they're living in a non-fluoridated area. Now, what happens if you have a mother coming into your practice, same, let's say with a 2-year-old child, but they are living in a fluoridated area? Now, in this situation, you know that they're living in a fluoridated area, but still there will be some conditions where you might still have to supplement the child. Okay, so in such cases you would ask them to collect the drinking water that has been supplied to them and send it for analysis. Okay, basically for fluoride analysis. And once the results come back, depending upon the fluoride concentration that has been given by the lab to you, you would decide as to which category they belong, whether they belong to the point 3 less than 0.3 ppm fluoride or between the 3 to 6.6 ppm fluoride. And depending upon that, you would give your or you would supplement the child with fluoride. Now, continuation of the again another case scenario is the age appropriate fluoride toothpaste to be dispensed for this child is a smear sized, entire length of the bristle, pea sized or rice grain sized. Okay, so this child is 2 years of age, right? And in such a case, what you would have to do is you will be going for your smear sized. Okay, and here is a picture of your smear size or your rice grain sized. Now let's look at scenario 2. Okay, now the case scenario that has been presented to you here is you've been invited to conduct a fluoride program for a small class of 30 students aged between 8 to 10 years. Identify which one of the following program would be ideal to perform. Okay, so here it's you're a general dentist and you have been invited, and the age group is very important. You have 8 to 10-year age group, so which means they are essentially in a mixed dentition stage. All right, so which one of the programs would be ideal? Toothbrushing program, fluoride mouth rinse program, C, fluoride tablet program, and D, all of the above. uh, Actually, the D should have been any of the above. So you can choose any of these programs, or you could choose any two of these programs depending upon the children. Okay. Let's look at the case scenario 3. Okay. So you have a child with cerebral palsy who comes to you for a dental checkup. The preventive program against caries for this patient will be A, oral prophylaxis, B, extractions, C, fluoride therapy, and D, which is a combination of option A and option C. So what would be your pick for this particular question? So the correct answer is option D. Okay, extractions are not a part of your preventive program. Okay, oral prophylaxis and fluoride therapy would be appropriate, or the most appropriate one would be just fluoride therapy. But since you already have oral prophylaxis in your option as option A, I would go with a safer bet, which is option D. And if you have chosen fluoride therapy, your mode of delivery of fluoride will be fluoride varnish, fluoride mouth rinses, fluoridated chewing gums, D, any of the above. Now, you have to remember that you are dealing with a child with cerebral palsy, okay? So, usually children with cerebral palsy have problem with your muscle tone, all right? So, fluoride mouth rinses and fluoride chewing gums are out of your question here because they need some amount of muscular control. So the best option or the safest option for this question would be option A, just fluoride varnish. Now let's look at the fourth case scenario, okay, which is a 6-year-old autistic child has multiple restorations in your teeth. So again, you're having a special child, and this time it is an autistic child who's come to you. Okay, what would you recommend as a part of preventive management for this particular patient? A, pidden fissure sealants, at-home use of fluoridated toothpaste twice daily, in-office application of fluoride varnish, D, all of the above. Now, you have to remember that autistic children are very sensitive to different textures and different tastes. Okay, so the best answer would be option D, all of the above. So, if any of this don't work, let's say he does not, or this child does not like the fluoridated toothpaste, or he does not prefer the application of fluoride varnish. If any of this does not work, then the safer bet is to go for all of the above. You know, do all of that is required because he already has multiple restorations on the teeth. So the best preventive would be to choose sealants, toothpaste, and fluoride varnish. If you choose to use neutral sodium fluoride, the child will have to visit for applications at 8 years, 10 years, and 12 years of age. Option B is 7 years, 11 years, and 13 years of age. Option C is 7 years, 10 years, and 12 years of age. And option D is 8 years, 11 years, and 13 years of age. So if you go back and remember, we talked about the neutral sodium fluoride application, which is known as the Knutson's technique. Correct? All of you are with me on this? Yeah? So the neutral sodium fluoride is your Knutson's technique, all right? So according to Knutson, he said that the age for application would be option B, okay? 7, 11, and 13 years, because these age groups basically tend to match with the time tooth are erupting. At 7 years, you would have had your mandibular incisors and maxillary incisors in place. Around 11 years, you're going to have all your premolars in place. And around 13 years, you're also going to have your second premolars and possibly your second molars in place, okay? So at this time is the best time for the child to receive your neutral sodium fluoride applications. Now, this is a fifth case scenario, okay? So you are presented with a child or a 13-year-old boy with Down syndrome, all right? He's cooperative and has no other relevant medical history. He is caries-free apart from spots of decalcification in the buccal surface of the lower second primary molars. Okay. Question. His mother requests that these teeth are restored. Which of the following is the most appropriate management? All right. A, extraction. B, reassurance that these teeth can be left until they exfoliate naturally with no treatment being necessary. C, recommend the use of topical fluoride. D, reassurance that these lesions will not cause any harm. Okay. So any spot decalcification is basically an starting of your enamel caries. Okay, that's how your enamel caries starts, right? And they clearly say it is on the buccal surface of the lower molars, and we're talking about your lower second primary molars. And since the child is about 13 years of age, all right, ideally these lower secondary molars should be should have exfoliated. Okay, maybe because of his condition present here, they are showing a delayed exfoliation. So best answer would be option B, reassurance that these teeth can be left until they exfoliate naturally with no treatment being necessary. Okay, so if this question had been changed, okay, let's say 13-year-old boy and lower second permanent molars were there, or the first permanent molars were there. In such cases, you would have recommended a topical fluoride application. I hope this question is clear to you. Yeah, if you can say yes or no, I would be happy to just read your message on the chat box. Okay. Now, we are still talking about this thin white lesions. Okay, thin opaque lesions which are seen on the cusp tips, incisal, or the marginal ridges. Okay, this question is not related to the previous case scenario. Let me be very clear. Thin opaque lesions which are seen on the cusp tips, incisal, or marginal ridges is snowflake appearance, snow-driven appearance, snow cap appearance, snowfall appearance. So with dental fluorosis, the initial stages, you're going to see something known as the snow cap appearance, which is option C. Now, this is another interesting question that I came across. All right, lower extremity pain syndrome. All right, so the syndrome as lower extremity pain syndrome is due to A, increase in serum fluoride levels, increase in fluoride levels in the CSF, increase in fluoride levels in the saliva, and increase in fluoride levels in the synovial fluid. Now, the correct answer is option A. Okay, so it is basically the increase in the fluoride level, serum fluoride levels. Now, what exactly is this lower pain extremity syndrome? It is basically a seen in periarticular foot pain. Okay, and is usually the patients present with tenderness, and they have been described in the large joints. Okay, so if you're being described with large joints, the basic culprit is not because the synovial fluid or the CSF, it is the serum fluoride levels. Okay, high concentrations of the serum fluoride levels cause something called a lower extremity pain syndrome. And this is another situation. You're having a 15-year-old female who has lived in a non-fluoridated area all her life. Okay, which of the following is likely to occur in this young lady when she moves to an area where water naturally contains 6 ppm of fluoride? Now, 6 ppm of fluoride is definitely not the recommended amount of fluoride that you need to have in water. Okay, but this 15-year-old child has been living in a non-fluoridated area, right? So, A, you see a 50% reduction in the caries. B, moderate level of dental fluorosis. C, you see an increase in the amount of fluoride that is stored in the bones. D, GI problems. Okay, so the question is what you're most likely to occur is option C. It is basically an increase in the amount of fluoride that is stored in the bones. Now you can actually ask me why you can't see a 50% reduction in caries. That is because a 15-year-old child, she would have had all her permanent dentition in place, except probably for the third molars, which are not erupted. Okay, so a 50% reduction in caries is definitely not going to happen because it's a very high amount of reduction. And 6 ppm of fluoride for a short period of time is not going to give that much amount of reduction. So you can eliminate option A. Okay, and also option B, mild level of dental fluorosis. Again, it cannot happen because by the age of 50, all the dentition is in place. Okay, and they have gone to the post-eruptive enamel calcification. Again, with an exception of the third molars. Okay, so you cannot see mild dental fluorosis. The most likely that you can see is an increase in the amount of fluoride which is stored in the bones. GI problems could be a chance only if she's ingested too much amount of fluoride water in one go. So you can have an acute toxicity, but again, that is not very likely to occur. The question says which is likely to occur, and option C is the safest bet. Now, this question deals with your lethal dose of fluoride, which is typical for a 3-year-old. Is approximately A 100 mg, B 200 mg, C 350 mg, and D 500 mg. Okay, so what would be your pick for this? I know this is a tricky question, so I'm going to wait for your answers. All right, and let's see who's going to get it right. And if you get it right, I definitely want an explanation from you all. Okay, I'm going to give a second here to key in your answers for me. So the answer is option D. Okay, let me tell you how. The lethal dose of fluoride is anywhere between 16 to 32 milligrams per kg body weight. Okay, an approximate weight of a 3-year-old child is going to be about 15 kgs. Okay, and any healthy normal child, it is going to be 15 kgs. Okay, so per kg body weight, the maximum dose of lethal dose is 32 milligrams, right? So if you convert that milligrams into kgs, it comes at 0.32 kg, correct? So now for 1 kg, it is 0.32 kgs of fluoride, which is the lethal dose. So for 15 kg, that is the approximate weight of a 3-year-old child, the maximum lethal dose is at 4.8 kg. Okay. Now, if you convert that, it's going to be around 480 milligrams. All right. So the closest answer that you are going to get is option D, which is 500 milligrams. Okay. So this is the last question of the day. In a young patient living in an area with community water fluoridation, the fluoride concentration of an erupted tooth, okay, talking about an erupted tooth, is greatest A, at the DEJ, B, surface of the clinical crown, C, at the layer of the dentine nearest to the pulp, D, evenly throughout the enamel. Okay, you will be confused, I'm sure, with option B and option D. Okay, evenly throughout the enamel can be easily ruled out here because the question says erupted tooth. Okay, the tooth is already erupted. So in such cases, the highest concentration of fluoride is seen in the surface of your clinical crown. Okay, so this is the last question for the day, and we can wrap up our live class. If you have any doubts, so please do let me know in the chat box that is available with you. Okay, and I will wait for a couple of seconds before I officially close this live today. I hope it was all useful for you, right? Some questions were basic revision, okay? Some of them were new questions, and some I'm sure that it really made you think, right? Especially the case scenarios and all that. So please do leave your comments and your questions in the chat box that is available with you, and I will take it.